Hello, and thank you for joining us for Rare Ovarian Cancers, What's New? We're lucky to be joined today by Dr. David Gershenson for a discussion focused on new research and treatment of rare types of ovarian cancer. Dr. Gershenson is professor in the Department of Gynecologic Oncology and Reproductive Medicine at the University of Texas MD Anderson Cancer Center. You can view his full bio in the downloadable conference program. Thank you so much for joining us, Dr. Gershenson, and I'll turn it over to you.
Well, thanks very much for that kind introduction. It's really a pleasure to present again at the OCRA annual conference this year on the topic of rare ovarian cancers. The last couple of times I presented at this conference, the subtitle was, "Are we making progress?" But now, today in 2020, I think there's good reason to state this much more positively and to say we are making progress. And I hope to show you how we are doing that over the past year or so. These are my disclosures. In the short time we have together, here are the subtypes of rare ovarian cancers that we'll be discussing: malignant ovarian germ cell tumors, ovarian sex cord stromal tumors, mucinous carcinoma, clear cell carcinoma, and finally low-grade serous carcinoma. So first, malignant ovarian germ cell tumors. These represent less than 5% of all ovarian cancers. They occur primarily in girls and young women in their 20s, maybe 30s, rarely older than that. Prior to the 1970s, most patients did not survive. But since the introduction of modern chemotherapy in the late 1970s, in the form of the bleomycin etoposide cisplatin regimen, the cure rate is approaching 100%. Because this tumor almost always involves one ovary, fertility-sparing surgery is feasible in most of these young patients. And the current research that I'll briefly discuss today revolves around limiting the extent of primary surgery and reducing the toxicity of chemotherapy. So this is an international trial in which both children and adults, males and females, are enrolled. And for females with ovarian germ cell tumors who have disease confined to one or both ovaries, they undergo observation following primary surgery, and they only receive chemotherapy if they develop a recurrence. So the concept behind this part of the trial is to obviously avoid chemotherapy altogether in a subset of patients who have very early stage disease. This trial, as I said, is ongoing, and it will probably be another 5 years or so before we have the results of this trial. But I think it's very exciting to know that we may be able to limit both the surgery, because the surgery required for this trial is much less than the usual extensive comprehensive surgery, as well as limiting or avoiding altogether chemotherapy. In the other part of this trial, patients with a little more advanced disease, stage 1C to 3, are randomized to the standard regimen of bleomycin etoposide and cisplatin for 4 cycles versus bleomycin etoposide and carboplatin. And the concept underpinning this part of the trial is that carboplatin is thought to be much less toxic in terms of both acute and long-term side effects. And so again, if this trial proves to be positive, it will represent a major advance in lessening both the short-term and long-term toxicity of chemotherapy for germ cell tumors. Next is ovarian sex cord stromal tumors, and of course the most common type is granulosa tumor of the ovary. These tumors on the whole represent 2% of all ovarian malignancies. They're usually stage 1 and they're usually unilateral. So again, fertility-sparing surgery is possible in most young patients. But surgery does play a key role in terms of the cornerstone of management for this disease. And that also includes not only primary surgery, but also secondary surgeries. Almost all granulosa cell tumors do have a FOXL2 mutation, but unfortunately, there are no drugs that target this mutation, so it's not really practically actionable at this point in time. Hopefully that will change. The standard postoperative treatment for most patients, except those with stage 1A, is platinum-based chemotherapy. And for patients who relapse, we always recommend molecular tumor testing, since we are limited in terms of number of options of treatment for these patients. But once relapse does occur, secondary surgery may be employed. It could be other types of chemotherapy. Bevacizumab or Avastin is an active agent in these tumor types, and as well as endocrine therapies, aromatase inhibitors, tamoxifen, etc. And of course, we encourage patients to enroll on clinical trials. So this is the NCCN guideline for ovarian sex cord stromal tumors. And following primary surgery, as you can see, for patients with stage 1 disease, it's recommended that they are observed and have no postoperative therapy. For patients with high-risk stage 1 disease, so rupture or other high-risk features, the recommendations are either observation or platinum-based chemotherapy. And so this area in particular is somewhat controversial. But for all other patients who have stage 2, 3, or 4 ovarian sex cord stromal tumors, platinum-based chemotherapy, or occasionally radiotherapy on a limited basis may be recommended. I think the big news this year in this subtype ovarian sex cord stromal tumors is GOG 264. This was a randomized phase 2 trial of the standard paclitaxel carboplatin versus another standard regimen, bleomycin etoposide and cisplatin, for patients who have newly diagnosed advanced stage and recurrent chemo-naive sex cord stromal tumors of the ovary. So patients following surgery were randomized to one of these two options. And we've learned very recently that this trial closed early because of futility. Now, it's going to be presented shortly at the International Gynecologic Cancer Society meeting that will be held virtually as well. But the hint is, the suggestion, because it has closed early for futility, is that the investigators will not be able to find any difference between these two regimens. If that's the case, I think that's good news, because what it means is probably most of us will completely abandon the more toxic BEP regimen on the right and utilize carboplatin and paclitaxel. But I think we need to wait to hear for the results presented at that meeting. Moving on to mucinous carcinoma. So the next 3 subtypes will be rare epithelial ovarian subtypes, and the first is mucinous carcinoma. As you can see, this accounts for about 25% of stage 1 epithelial ovarian cancers, but only about 5% of advanced stage disease. It's often confused with a gastrointestinal primary cancer, such as colon cancer or gastric cancer. In terms of overall survival, it's very similar to high-grade serous cancers at about 80% 5-year survival for stage 1, But when mucinous carcinoma is diagnosed in the advanced stages, it's significantly worse than high-grade serous cancers. And again, the standard therapy historically has been surgery followed by paclitaxel carboplatin chemotherapy. Again, this is the NCCN guideline. And as you can see, following primary surgery for stage 1A and 1B, the recommendation is observation. And as noted, fertility-sparing surgery is feasible in most young patients with this disease. For stage 1C, like in ovarian sex cord stromal tumors, the recommendations are either observation or systemic therapy with platinum-based chemotherapy. But for stage 2, 3, and 4, again, the recommendation would be systemic therapy with platinum-based chemotherapy. We know that there are a few key pathways and potential targets, particularly for patients if they do develop a recurrence of disease. We know that bevacizumab can be an active agent in mucinous carcinoma, so the angiogenesis pathway is certainly a key pathway. About 20% of mucinous carcinomas have a microsatellite instability high, which means that they may be responsive to immune checkpoint inhibitors. About 20% or so have a HER2/neu amplification, and breast cancer drugs such as trastuzumab that targets HER2/neu may be active in this disease as well in patients who do express HER2/neu amplification. And then about 40 to 50% of mucinous carcinomas have a RAS mutation. And because this is one of the genes in the MAP kinase pathway, we know that MEK inhibitors may be active in tumors that express the RAS mutation. There's interest in HIPEC for mucinous carcinoma. As you know, heated intraperitoneal chemotherapy has been studied in ovarian cancer in many reports with, I would say, mixed results. And currently, most experts consider it to be investigational and not part of standard of care. They really believe it belongs within clinical trials because we do need to study it further. However, there is particular interest in employing HIPEC for mucinous carcinoma of the ovary because it's been used historically for a number of years in gastrointestinal cancers, which, as I've said, microscopically look very similar to ovarian mucinous carcinoma, may be confused with it. And so I think this is being employed in some centers in women who have mucinous carcinoma of the ovary. This was a trial that was developed a few years ago by investigators in the United Kingdom and the United States, in which patients with mucinous carcinoma of the ovary, stage 2, 3, and 4, primarily, were randomized to either the standard regimen of carboplatin and paclitaxel or to a regimen that's commonly used for colorectal cancer. And one of these is oxaliplatin capecitabine. And again, the concept here was to see if by giving a GI regimen instead of the standard ovarian cancer chemotherapy, we would see a much higher response rate and progression-free survival. There was also a secondary randomization between bevacizumab and no bevacizumab. Unfortunately, this trial closed early due to slow accrual. So we will never have a conclusion from this study, unfortunately. However, there is some good news. This is a retrospective multi-institutional study that was reported last year. There were 52 patients who had mucinous ovarian carcinoma in this study. and half of them received the standard paclitaxel carboplatin regimen, and half received some type of gastrointestinal regimen, as you can see there. In addition, 14 of the 52 patients also received bevacizumab, which I previously said does have activity. And what you can see by the curves, the progression-free survival on the left and the overall survival on the right, is that patients who received the GI regimens had a significantly better progression-free survival and overall survival than the women who received the standard paclitaxel carboplatin regimen. Again, this was retrospective, not a randomized clinical trial. So further investigation is clearly needed, but I think this is a hint that we may be starting to see some progress in the management of mucinous carcinoma of the ovary. On to clear cell carcinoma. This also accounts for about 5 to 10% of all ovarian neoplasms. Interestingly, it's thought to usually arise from foci of endometriosis within the peritoneal cavity. Most patients present with early stage disease, just like with mucinous carcinoma. And also just like mucinous carcinoma, the prognosis for patients with early stage clear cell carcinoma is very similar to high-grade serous cancers, but in the advanced stages, clear cell carcinoma has a much worse outcome than the typical high-grade serous carcinomas. Again, this is the NCCN guideline, fairly straightforward. Following primary surgery, the options for stage 1A confined to one ovary are either platinum-based chemotherapy or observation. Again, as you can see, there's some controversy about the utility of chemotherapy in this disease when it's confined to the ovary. But for all other patients, pretty much platinum-based chemotherapy is the recommendation. We also know that this tumor has key pathways and potential targets. So the ARID1A gene is mutated in about 50% of these clear cell carcinomas, and there are drugs. I've listed one, tazemetostat, that potentially target that gene mutation. About 30 to 40% of clear cell carcinomas have a PI3 kinase, AKT, or mTOR pathway aberration. And again, there are several drugs out there that target these gene mutations. Again, the angiogenesis pathway is active, so bevacizumab is an option. And we also know that these tumors express frequently PD-1 or PD-L1, and immune checkpoint inhibitors are options as well. And then I've listed a number of other less well-studied potential targets there on the slide as well. There have been actually a number of trials that have been conducted over the past, I would say, decade, specifically for women with clear cell carcinoma. The first two on this list are for frontline or first-line chemotherapy. The first was a Japanese trial that compared the regimen of irinotecan cisplatin to the standard of paclitaxel carboplatin, and the investigators found no difference in outcomes. So that was a negative study. As was the second study there, which was a GOG study in which patients were with clear cell carcinoma stage 3 and 4 were treated with paclitaxel carboplatin, but with the addition of an mTOR inhibitor, temsirolimus, and then temsirolimus maintenance. Again, compared to historical controls, this trial did not show any advantage over standard therapy. And then the last three studies on this slide were for recurrent clear cell carcinoma with targeted agents, sunitinib, cabozantinib, and ENMD-2076. And none of these three studies showed any great activity and were negative studies. There are some other studies. There are a couple of studies that have been completed in terms of enrollment. The first two you see there with dasatinib and nidtad-arib, but both of these are pending analysis. There's another study that's on hold with tazemetostat. And then finally, there is a study with an ATR inhibitor for women who have clear cell carcinoma that is ongoing. But I think the hottest news in clear cell carcinoma is really related to the activity of immune checkpoint inhibitors or immunotherapy. So this was an early report from 2015, patients with ovarian cancer treated with nivolumab, which is an immunotherapy agent. This is one patient in that study, a 60-year-old woman who had recurrent clear cell carcinoma of the ovary. And she had previously received 3 lines of conventional chemotherapy. And as you can see in the images of her CT scan, before on the left, after on the right, after 4 months of treatment, she had a significant response to treatment with nivolumab. And you could see on the right, the dramatic decrease in her serum CA-125 level. So that was an early hint that immune checkpoint inhibitors may be very active in clear cell carcinoma. This is a study that was just recently reported this year. It's a phase 2 trial of, again, nivolumab, but randomized against the combination of nivolumab and ipilimumab. There were 100 patients enrolled in this trial, and 12 of the patients had clear cell carcinoma. And as you can see from the objective response rates, the women who received the combination had a significantly better response rate, 31% versus 12% in the single agent arm. And interestingly, patients with clear cell carcinoma had a 5-fold odds of response compared with the other subtypes of ovarian cancer enrolled in this study. So again, a really interesting data that indicates that immune checkpoint inhibitors may have a very nice activity in patients who have recurrent clear cell carcinoma. And now there are actually several other trials studying immune checkpoint inhibitors. This is a trial of the NRG that's currently open, although on hold for the time being. It will hopefully reopen soon with pembrolizumab and an IDO inhibitor as one example. And then here's another study from Asia in which, again, pembrolizumab is being used in combination with another drug in women who have recurrent clear cell carcinoma. And yet another study from Asia in which women with recurrent clear cell carcinoma are enrolled in this study with a randomization to another immune checkpoint inhibitor, durvalumab, versus kind of a standard platinum-resistant chemotherapy drug, Calyx or Doxil. So these are a number of examples of trials that are ongoing with immune checkpoint inhibitors. And there I can mention even another trial ongoing at MD Anderson with a combination of immune checkpoint inhibitors that also looks very promising for clear cell carcinoma. And then finally, low-grade serous carcinoma of the ovary. This accounts for about 10% of all serous carcinomas. We know that it can arise de novo or following a diagnosis of a serous borderline tumor, generally years later. This tumor is characterized by younger age of diagnosis, relative chemoresistance, responsiveness to endocrine therapy such as aromatase inhibitors, as well as prolonged overall survival when compared to the much more common high-grade serous ovarian cancers. However, like high-grade serous ovarian cancer, most patients present with advanced stage disease, and unfortunately, over 70% of women will at some point relapse. We know that the MAP kinase pathway plays a very prominent role in the pathogenesis or development of low-grade serous carcinoma, and I'll have more to say about that in a moment. Again, the NCCN guidelines for following primary surgery for stage 1A and 1B, observation is recommended, no postoperative therapy. For stage 1C, again, you have this controversy of observation versus chemotherapy. And then for stage 2, 3, and 4 patients, the recommendations are either chemotherapy followed by hormonal maintenance therapy with a aromatase inhibitor, for instance, versus just giving an aromatase inhibitor alone without prior chemotherapy. And these have been the two most popular options employed off protocol for patients with advanced stage low-grade serous carcinoma. I mentioned key pathways and potential targets. So the MAP kinase pathway is very prominent in this disease. And so we know that up to 40% of tumors may have a KRAS mutation, 5 to 10% will have a BRAF mutation, and up to 26% may have an NRAS mutation. Over 90% of these tumors express the estrogen receptor. So again, hormonal therapies like aromatase inhibitors may be active. And then again, as with many of the other types we've discussed, bevacizumab seems to have activity as well. So this just illustrates in the primary adjuvant setting following primary surgery, the fact that women who have measurable disease with low-grade serous carcinoma following primary surgery are much less responsive than women who have measurable disease with high-grade serous carcinoma. So response rate was 23% versus 90% in the high-grade serous carcinoma patients. Again, the same concept or principle is true not only for adjuvant chemotherapy, but also for neoadjuvant chemotherapy, as well as maintenance therapy or the therapy for relapse or recurrence. So it doesn't mean that low-grade serous carcinoma is completely unresponsive to chemotherapy. It's just not as frequently responsive as the more aggressive high-grade types. I mentioned bevacizumab. There are two studies, one from Memorial Sloan Kettering and the other from MD Anderson, that show that women with recurrent low-grade serous carcinoma who receive bevacizumab either as a single agent or in combination with chemotherapy have up to a 40 to 50% response rate. So a very active agent in this disease. Likewise, endocrine therapy is active as well. Letrozole and anastrozole aromatase inhibitors have response rates in the range of 13% in 3 different studies. But you can also see in the right-hand column that there's a large proportion of patients in all these studies who may have stable disease, sometimes for several months or even several years. So these are very active agents. Tamoxifen also has activity, but we do believe now that it's lesser than the aromatase inhibitors. So while it is an option, it would not take precedence over a recommendation of an aromatase inhibitor. Also for endocrine therapy, as I mentioned, there are a couple of trials. The one on the left is a maintenance therapy trial, and the one on the right is an adjuvant therapy trial. So at MD Anderson, we reviewed 203 patients. 133 of these patients following primary surgery received chemotherapy alone, and 70 patients received chemotherapy followed by a hormonal agent as maintenance. And what we found was there was a significant improvement in progression-free survival for the patients who received the hormonal maintenance therapy following chemotherapy. The median survival in that group was 65 months versus 26 months in the patients who received chemotherapy alone. And very similarly, on the right in the Johns Hopkins study, they reported 27 patients treated with surgery, followed by only hormonal therapy, so no chemotherapy. And they had very promising results as well. The 3-year progression-free survival was almost 80%, and the 3-year overall survival was 93%. So not as a long follow-up as in the MD Anderson study and a smaller group of patients, but a very promising report on hormonal therapy alone without chemotherapy. And these two retrospective studies have now served as a background for this clinical trial that was activated in the fall of 2019, in which women with stage 2, 3, or 4 low-grade serous carcinoma of the ovary or peritoneum following primary surgery were randomized to either paclitaxel carboplatin followed by letrozole maintenance until progression, or just to letrozole monotherapy without any chemotherapy. As I said, this trial is ongoing. The target is 450 patients. And again, it will be about 5 years or so before we have an answer from this study, unless it should close early because of futility and not being able to really discern a difference in these two arms. So this is an interesting study and may allow us at some point in the future to completely abandon chemotherapy if in fact the letrozole arm performs at least as well. Not even better, but just at least as well. Following the endocrine therapy theme, this is an ongoing study for women with recurrent low-grade serous carcinoma treated with letrozole plus a CDK4/6 inhibitor, ribociclib. It's an ongoing study for about 50 patients. There have been about 25 patients accrued on this study, so we're halfway there. And again, the concept underpinning this study is whether the addition of a CDK4/6 inhibitor will improve the outcome for women treated with letrozole in addition to the CDK4/6 inhibitor compared to letrozole alone, as has been found in many breast cancer studies. And so if this trial does look positive, it may lead to a randomized trial against letrozole as a single agent. Another study with endocrine therapy is for neoadjuvant treatment. So for women who present with very extensive stage 3 or 4 disease that is thought to be possibly unresectable at the time of presentation, there is a pilot trial at MD Anderson in which patients receive another hormonal agent, fulvestrant, in combination with a CDK4/6 inhibitor, abemaciclib. And this trial, again, is ongoing. We've accrued about 5 patients, and it will be interesting to see if, in fact, the outcomes in these women are better than when compared to the historical controls of women treated with neoadjuvant chemotherapy. And then on to MEK inhibitors or other targeted agents for low-grade serous carcinoma. This was the first trial of a MEK inhibitor, selumetinib, a phase 2 trial in 52 women with recurrent low-grade serous carcinoma. The response rate was 15%, and another 65% of women had stable disease for a clinical benefit rate of 80%. Unfortunately, there was no correlation between outcome or response rate and whether or not the patient's tumors harbored a KRAS or BRAF mutation. So, what we were looking for there was a hint of a biomarker, but that did not pan out in this study. These are images from one of the patients in that first MEK inhibitor study. And as you can see, this patient did have her tumor did contain a KRAS mutation. And on the left is the before and on the right is the after. And you can see that one of the tumor areas in the peritoneal cavity did reduce by 50%. This is also a patient on that selumetinib study who's skydiving following 100 monthly cycles of the drug on GOG 239. So there were some patients who actually derived dramatic benefit from the MEK inhibitor and actually were able to receive it for a few years even. BRAF inhibitors have also been reported in case reports primarily. There have been no large studies. And this is, you can see there's a low-grade serous carcinoma patient in this study of non-melanoma cancers reported who had a prolonged response to a BRAF inhibitor in that her tumor did harbor a BRAF mutation. So that's yet another example of an actional mutation treated with a targeted agent. So subsequently, there have been 2 large randomized clinical trials of MEK inhibitors. This is the first one, Milo-INGOT study, a phase 3 study. In this trial, women with recurrent low-grade serous carcinoma were randomized to either a MEK inhibitor, binimetinib, or one of 3 chemotherapy agents that are commonly used and are standard: pegylated liposomal doxorubicin or Doxil, paclitaxel, or topotecan. There were 341 women randomized in this study. Unfortunately, the study closed early because it appeared that the investigators would not be able to discern any difference in the outcome, either in terms of progression-free survival or response between the 2 arms of this study. In other words, they would be similar, the MEK inhibitor to the chemotherapy drugs. And as you can see, particularly in the in both of these curves, but particularly the one on the left, that the median progression-free survival for the MEK inhibitor was 10.4 months, and it was 11.5 months for the chemotherapy arm. So no difference in the outcome of progression-free survival. And that is why this trial closed somewhat early and was a negative trial. Likewise, the response rate was no difference. It was actually 24% in both of the arms, the MEK inhibitor arm as well as the chemotherapy arm. But there was a very interesting finding in this study. Unlike in the selumetinib phase 2 study, investigators found that, and they compared the patients who had binimetinib, the MEK inhibitor, those whose tumors harbored a KRAS mutation compared to those whose tumors did not harbor a KRAS mutation. And they found a significantly improved progression-free survival, 17.7 months versus 10.8 months for the tumors that were negative for a KRAS mutation. And likewise, they also found that the response rate was higher for those patients whose tumors had a KRAS mutation. So this is early information that needs to be confirmed in other studies, but very, very interesting and sort of supports what many of us had thought but were not able to demonstrate in the original selumetinib study. The other large randomized trial was GOG 281, in which patients were randomized with recurrent low-grade serous carcinoma to another MEK inhibitor, trametinib, versus one of 5 standard agents. There were 2 hormonal agents, letrozole and tamoxifen, and the same 3 chemotherapy drugs that you saw in the Milo study. 260 patients were randomized in this trial, and unlike the Milo study, this trial was a positive trial. We found that the MEK inhibitor performed significantly better than the standard of care arm. And so the median progression-free survival was 13 months for trametinib and 7.2 months for the control arm. Likewise, the response rate was significantly better in the MEK inhibitor arm, 26.2% versus 6.2% for the standard of care arm. Also, the response duration in terms of months, the median was 13.6 months for trametinib and only 5.9 months for standard of care. And on the lower part of this slide, you can see the response rates for each of the 5 agents in the standard of care arm. And the one with the highest response rate was actually letrozole. This displays the side effects, some of the side effects that occurred in the GOG 281 trial. On the left are the side effects associated with trametinib, and on the right, side effects associated with standard of care. But if you focus on the left-hand side in blue, you can see that the most common side effects with trametinib were skin rash, gastrointestinal side effects such as nausea, diarrhea, abdominal pain, constipation, etc., as well as fatigue, hypertension, and anemia were the most common side effects. So it's not an innocuous drug, although it is oral, as all the MEK inhibitors are. It still does have some significant potential side effects. So in conclusion, I believe I've tried to show you that there has been progress with each one of these rare tumors in the past 12 months. For malignant ovarian germ cell tumors, although the study is ongoing and won't be completed for a few years, I think it's very encouraging that we have a trial that we all very much believe will show us that less extensive surgery will be feasible, and that hopefully we can avoid chemotherapy altogether in a subset of these young patients. For ovarian sex cord stromal tumors, the news revolved around GOG 264, and if in fact it did close early for futility, we can hope that we will be able to abandon altogether the bleomycin etoposide cisplatin regimen, which is significantly more toxic than the paclitaxel carboplatin regimen. For mucinous carcinoma, I think HIPEC may offer some benefit in these patients, but importantly, I think we are moving towards the use more commonly of gastrointestinal chemotherapy regimens versus the old standard of paclitaxel carboplatin, although, as I've said, more information is needed in this area. Probably one of the most exciting advances has been in the area of clear cell carcinoma with the advent of immune checkpoint therapies, and I think once several of these trials are completed, we will see that this will become a new standard for women with relapsed clear cell carcinoma. And then finally, in the area of low-grade serous carcinoma, the good news is the effectiveness of MEK inhibitors, which I believe will represent a new standard for women with recurrent low-grade serous carcinoma. Although it is not yet FDA approved for low-grade serous carcinoma, it has already been added to the NCCN compendium or guidelines. And so I believe that will represent an advantage for women in terms of authorizing insurance coverage. So thank you very much for your attention.